Okay, it looks like it's top of the hour. Thank you everyone for joining us today for this first global webinar of 2021. Happy New Year to everyone. A couple quick things before we get started. You can use the chat function to submit any of your questions during the webinar, and we'll try to get to those at the end. And for the U.S. attendees, your certificates will be available on Monday at logging into your account. As I try to get Diane on, Nanya, if you'd like to introduce Lars and Diane, go right ahead.
Thank you, Kim. Welcome, everyone. My name is Nanya Hernandez, and I'm the head of Global Medical Affairs and Education at Medela headquarters in Switzerland. So as part of our efforts to really provide you with reliable information and the latest research results on breastfeeding and human milk and the safety and health of pregnant women and nursing mothers and their babies during these COVID times, at Medela, what we did was establish a bespoke webinar series that has been bringing to you the world's leading experts in human milk and lactation to highlight their research targeted specifically at navigating the impact of COVID on breastfeeding and lactation. So today's webinar is a part of that series. So thank you very much for joining us today, and welcome back if you have already been with us in the past webinars. The installment we have today is the first one of this year, as Kim pointed out, and it's the 9th webinar of our COVID and breastfeeding series. And we're really happy to have good friends of ours here today. Professor Diane Spatz from the University of Pennsylvania and the Children's Hospital Philadelphia, and Professor Lars Bode from the Larson Rosenquist Foundation Mother Milk Infant Center of Research Excellence, easier remembered as MommyCorps, and the University of California, San Diego. They will be talking to us about their recently published paper promoting and protecting human milk and breastfeeding in a COVID-19 world and beyond. Now, since yesterday, call that good timing, their full paper is freely available online in Frontiers in Pediatrics. And the article is the result of 9 leading experts in breastfeeding, lactation, immunology, and virology, namely Diane and Lars, Ricardo Davanzo, Donna Guedes, Yanis Müller, Hans van Goudewe, Rebecca Powell, Virginie Rigaud, and Anne Yates, who came together at a roundtable event hosted by Medela last year to share their expert observations, their research, and their recommendations to support breastfeeding mothers and clinicians during the pandemic. So this paper is really what came out of that discussion, of that roundtable. And it's I was lucky to be there. The energy and the passion that they have for the whole subject, I'm sure, will be evident to you when they talk to you to us today. Before I hand over to Lars and Diane, please let me remind you to feel free to pop in your questions in the chat function and the question function. We should have enough time to address them at the end of the talk. And now, please welcome Professor Lars Bode.
Yeah, good morning. Thank you very much, Nanya, for introducing us. That roundtable clearly was a real pleasure to be part of, and how timely that we are talking about something that just got published yesterday. So I'm going to kick this off, and then Diane going to take the second part of the presentation. Once I get this started here, hold on. So we are going to talk about protecting human milk and breastfeeding in the COVID-19 world and beyond. And like we said already, can't be any more timely. This paper came out yesterday, is available for free online, open access. And you can see that the timeliness of this made available yesterday. We're talking about it today. So how much better can that be? Okay. So before I get started, a couple of disclosures where our research funding is coming from, and then I dive right in. So let's talk a few seconds here, because everyone is really familiar with this already, about the power of human milk. Always start my presentation with this sentence from the editorial in the Lancet Breastfeeding series that says that human milk can save lives. In fact, the death of 823,000 children and 20,000 mothers each year could be averted through universal breastfeeding, and that comes along with economic savings of $300 billion US. We know human milk saves lives. We're still losing a lot of infants and children to diarrheal disease, respiratory infections, and many other things. And we know, on the other hand, that children who are breastfed have substantially lower risk of suffering from these diseases. And we're always asking, what is it in human milk that makes it so powerful? We see specifically in the preterm infant space that necrotizing enterocolitis remains to be a problem. About 5% of all very low birth weight infants develop this disease. And on the other hand, again, preterm infants who receive human milk are much better off at a lower risk to develop this devastating disease. There are benefits for life. It's not just the immediate benefits for the breastfed infant, but really there is benefits for life. Breastfed infants later have a lower risk for overweight and obesity, lower diabetes risk, and are potentially even smarter. And not only that, there are also benefits for moms. So moms that breastfeed have a lower diabetes risk, lower cardiovascular disease risk, and are at lower risk to develop breast cancer or ovarian cancer. So all around, really, the power of human milk shows in multiple different aspects, short-term and long-term. And I'm going to skip this part here. Hold on a second. So now COVID-19 hit in February, March 2020. It feels like ages ago, but it's really not even a year. And there was this really sudden drop into a world of uncertainties when it comes to breastfeeding and human milk. So why is that? Why is there an uncertainty when it comes to human milk? Of course, the first question is it safe to breastfeed? Is the virus present in human milk? Is there a risk that baby can get infected through breastfeeding? And that was a very important decision or very important questions to answer to be able to guide and support parents and healthcare providers when it comes to breastfeeding, use of human milk, donor milk, many, many other aspects of it. So we had to find facts fast. It was all about what is the data? Can we generate data quickly to answer the question whether breastfeeding is safe when this new pathogen comes along? Just to give you a little bit of background here, when we started to get into this topic, there were a few published studies already, case studies, a few incidental reports that there was occasional presence of SARS-CoV-2 viral RNA in breast milk from recently infected women. And Kimberly Luckey and Ryan Pace put this nicely together in a review paper that came out in Maternal and Child Nutrition with this beautiful cover here, where they really highlighted what is the state of the art at that point in time. And this was about 10 months ago. And here's one of those examples of the studies that were available. This is a paper that came out of Germany, elegantly done, where they had a case report of two different moms that were rooming together in the hospital. Both got sick, and then it turned out that some of the milk samples that they tested were positive for SARS-CoV-2 mRNA, and of course that raised the alarm bells even more. So really that addresses a few or raises a few knowledge gaps here. How frequent does viral RNA occur in breast milk? So I showed you this one paper with two different moms, a few milk samples. Is it really that 50% of the moms have positive milk samples, or is that just a coincidence? And does the presence of viral RNA really represent active virus that can replicate and cause disease? Just because we're picking up RNA doesn't mean that there is a disease-causing agent in milk. So we started out, and this is really a true team science effort here, where we were very fortunate at UC San Diego to have what we call Mommy's Milk, which is a research biorepository that has been going on for about three and a half years. So way before the pandemic, where we recruit women, we asked them to send us milk samples, and then we biobank them, we analyze them, and we answer several different research questions. So we were able already to capture milk samples from moms that got infected early on in the pandemic, and then start working with those and see if there is virus in these milk samples. And the biorepository is led by my colleague Christina Chambers, Carrie Bertrand, and then we were very fortunate to team up with our colleagues at UCLA that I had worked with already during the HIV research times, and that's Grace Aldrovandi and her team. We got the emergency funding from the Lars and Rosenquist Foundation immediately, literally overnight. I got some personal donations and research. Medela was very supportive with in-kind supplies. And we also received support from milk banking associations here in North America. So to the first question, how frequent does viral RNA occur in breast milk? And show you this this graph here. What you see on the left is the participant numbers, 18 different women that we had recruited in the very beginning, and then you see the time from a woman's positive test on the y-axis, and every time you see a box there, whether it's white or black, that's where we had a milk sample available to analyze for viral RNA. So all these samples that you see here, we tested by RT-PCR. So that's to see if there is viral RNA in the samples. And indeed, we picked up this one sample over here that tested positive. Okay, so a little bit about coronavirus or viruses in general. What does this actually mean? We picked up RNA by RT-PCR. So if you take a closer look inside the virus here, there is, if you cut it open, you see there's spike proteins on the outside, and then there is there's RNA packed inside that capsule here. And that's really what we're picking up, right? We're picking up a fragment of this RNA that is packed inside the capsule. So keep that in mind. RT-PCR measures RNA fragments, but not an active live virus. So the next question was, well, if we pick up occasionally RNA in our breast milk samples, does that really represent viral RNA? And it's another small animation to what actually happens when you get a virus into your body. The airway epithelial cells get infected. The virus lands on the cell surface, gets incorporated, then multiplies inside the cell, and eventually pops up again, and then causes the disease by being multiplied in the epithelial cells. So how do you really test for an active virus in tissue culture or in the lab? We're not going to bring in people and infect them with a virus. We somehow have to find a model to do that. So again, we're very fortunate to team up with the UCLA group here, and Paul Krogstad did most of the work here, where we now take epithelial cells in a dish, which you see here in green, and then we can infect the cells with the virus. And this all needs to be done in BSL-3 labs because it's, of course, a contagious virus. And then we incubate the cells with the virus, wait 4 days, and then the virus multiplies and pops up, and we can measure that. So not only can we measure the virus, but also we see that the cells get destroyed. Now, this assay needed to be validated for human milk, because you can imagine if you now drop human milk into those cells, that could potentially be a problem. So the way we did that is we took human milk from way before the pandemic, from 2017, spiked virus into that human milk, added human milk to the cells, waited 4 days, and then measured the virus. So this is just to validate the assay that if there is virus in milk, can we pick it up? And yes, indeed, we can. So SARS-CoV-2 added to human milk is able to replicate. So we have an assay to identify active virus in human milk. Now, we went on and tested all these samples that we had from these 18 women, including the one that we tested positive by RT-PCR, and tested those in our cell culture assay. Waited 4 days, and we found indeed that none of the breast milk samples from SARS-CoV-2 infected women contained any replication competent, so active virus. And that included the one sample that tested positive for RT-PCR. In other words, just because there is viral RNA doesn't mean that there's a presence of a replication competent active virus that can cause disease. We've since confirmed this and validated this in a much larger cohort, just submitted this manuscript yesterday. And we're now up to 110 women. 65 of them were confirmed infections. And you see this here in this graph. So again, every time you see a number on the left, that's a different individual subject. And then we analyzed about 285 different milk samples. And out of those, 7 tested positive by RT-PCR, 1 for 7 different women. So that's about 6% if we take 7 out of 110. We then cultured all these milk samples, including the 7 that we tested positive by RT-PCR, and none of them were tested positive for active replication competent virus. So that shows us this presence of SARS-CoV-2 RNA in breast milk of infected women is extremely rare. And it doesn't mean that there is active virus in milk samples. Just because we pick up RNA doesn't mean there is an active virus. Now, the next gap was, what if human milk ever gets contaminated during pumping or handling? I'm just thinking about the milk banking industry, of course. So here we now tested milk and tested the effect of Holder pasteurization, which is often used in the milk banking to inactivate pathogens. Took SARS-CoV-2, added it to milk, now pasteurized it with the same conditions that Holder pasteurization is using in the milk banks, then tested that in our assay, and found after 4 days that Holder pasteurization indeed takes care of the virus and eliminates it. So Holder pasteurization inactivates SARS-CoV-2 in breast milk. Even if milk is contaminated with SARS-CoV-2 during pumping and handling, Holder pasteurization will take care of it and inactivates the virus. So another gap that we were able to fill pretty quickly. Okay, so in summary, for this part, the presence of SARS-CoV-2 RNA in breast milk of infected women is rare. It does not translate into an active virus that is replication competent and can cause disease. And Holder pasteurization inactivates the virus should breast milk ever get contaminated. So bottom line here is that transmission of SARS-CoV-2 from mother to infant through breast milk is very unlikely. Now let's switch focus from safety issues, which of course we had to address first, to benefits. So are there any human milk antivirals? So are there components in human milk that can actually stop the virus? And the first thing that comes to mind is antibodies. We know from previous work that if mom gets infected with a virus or with another pathogen, makes antibodies, those antibodies can make it into milk and protect the infant through passive immunity. So is that the same here? And this is work that our colleague Rebecca Powell in New York did and published recently in iScience. So I'm just presenting her work here since she was part of the workshop as well. So very elegantly, in a pilot study that they reported here, 15 different moms where they found in every single sample that there was specific spike protein specific secretory IgA. So you see 100% of the samples of the 15 samples had elevated titers for IgA that was specific to this coronavirus spike protein. And that's highlighted over here in the ELISA. You see everything that's over this threshold bar here is the samples that are from recently infected women. Okay, so that's antibodies, and I think this work is ongoing. This was just a pilot with 15 moms, but I think they have expanded that quite a bit recently. What about other antiviral components in human milk? We study oligosaccharides quite a bit, and we know they have antiviral properties against other viruses. So is it possible that oligosaccharides play a role here in the antiviral defense mechanisms of human milk? What about antimicrobial peptides and many other things? So these are really active research questions that we're addressing currently. And again, this is highly important to be able to guide and support parents and healthcare providers, because in the end, not only will we be able to say it's safe to breastfeed when you're infected, but you're actually doing something good because now you're bringing all these beneficial antibodies, oligosaccharides, and everything else to your child, and the breastfed child will be protected. Okay, so once this was cleared, the next challenge came right around the corner, and that was vaccines. So we published this letter here in the Lancet. It's currently in press, so it will come out the next couple of days. And that really questions breastfeed or be vaccinated, an unreasonable default recommendation. And this really came from the notion that breastfeeding women were not included in any of the current COVID-19 vaccine trials. And because they were not included to protect them from research, we had no data on safety for breastfeeding women and their infants. So at the very beginning, when the vaccine became available in the UK in early December, the recommendation was wait until you finish breastfeeding and then have the vaccine. And of course, that was not based on any biological plausibility for harm, but simply because there was no data. Just because women were not included, or breastfeeding women were not included in the vaccine trials, and there's no data, doesn't mean that there is any reason to believe that there is harm to the breastfed infant. So fortunately, those recommendations have changed very quickly, and I think most bodies now recommend that it's okay to be vaccinated and breastfeed at the same time. But once again, it's a time where we need to find facts fast to be able to give recommendations that are actually evidence-based. So we're currently doing a vaccination and breastfeeding study here at UC San Diego. And again, that is in collaboration with Tina Chambers' Mommy's Milk Biorepository, because now we're able to capture women that get the vaccine, that decided to continue breastfeeding, and then have milk samples that they can donate to us to analyze. So here the idea is that, can we measure maternal antibodies that are generated when mom gets the vaccine? So she starts making antibodies. Are those antibodies transferred through breast milk and then protect the breastfed infant from the disease? So we're currently collecting breast milk samples before and after vaccination, and then analyze those for SARS-CoV-2 specific antibodies. And we're looking also at infant outcome measures and multiple other things. And here, really, the notion is that recommending that breastfeeding women forego either vaccination or breastfeeding will have tremendous global public health consequences. And that's particularly true in low and middle income countries, where breastfeeding can be a life-saving measure. So in fact, we believe that vaccinating breastfeeding women may also benefit the breastfed infant. So we get a win-win. One dose of vaccine goes in, you're protecting two different people, mom and the baby. Okay, I'm bringing this back to the very first slide here, and that was about saving lives and the editorial in the Lancet Breastfeeding Series 2016. And I would say that we have to evaluate the risk of SARS-CoV-2 transmission through breastfeeding. But we already know the risks associated with not breastfeeding. So there is an urgent need to do this kind of research, and that's really one of the sentences in the paper that came out yesterday, that the current pandemic has uncovered the urgent and immediate need to invest in research that establishes the safety of human milk at crisis onset. So this needs to be rapid, right? We can't wait 12 months to write grants and wait until we get funding and get started, and maybe not. So this is an immediate need to invest. Otherwise, the gap in knowledge leads to fear-based confusion, misinformation, and amplifies the risk of breastfeeding cessation. And that's really something that that Diane will be talking about in the second part. What really happened in the field, in the clinic, with parents, with healthcare providers, as this pandemic hit, and we had all these gaps in knowledge that we needed to fill quickly. So I leave it with that and then hand it over to Diane.
Great, thank you so much, Lars. It was really, truly a pleasure being a participant in the Global Roundtables. And so Lars has given you that scientific background, and now I'm going to kind of delve into what we have seen happening around the world, and also, most importantly, a call to action for all of us. So the two objectives that I am going to cover is the impact of the pandemic on the provision of evidence-based lactation support and care, and identify effective strategies to change the current paradigm. And again, for COI disclosure, I was a participant in both global roundtables by Medela, and Medela is a sponsor of this webinar. So in this presentation, it's not informed only from my work on the Global Task Force, but work with the Research Affinity Group at the NIH in the US, the USBC COVID Response Team, our Congressional Task Force on Research specific to pregnant and lactating women, some work with the World Health Organization and Himbana on milk banking, and my work with the International Society for Researchers in Human Milk and Lactation. So one thing that's really interesting that Lars brought up is that pregnant women or lactating women were not included in any of the vaccine trials. And this is really important to acknowledge because what has been identified since the Congressional Task Force began to meet in 2017 is we've spent very little research money or investment in human milk and breastfeeding. And if you look at these two graphs here, they're small, but what you can see is that the smallest bar right here is the amount of studies in a decade published about lactation and milk supply. It's actually under 50. And if you look at those publications, less than half of them are actually research studies. So we have not invested our money in research support. So that is part of our call to action in our Frontiers article. The United States Breastfeeding has also engaged a COVID response team, and they have collected voices from the field. And you will see what they have found is very similar to what we have seen globally in our task force meetings. The fear and uncertainty that Lars has discussed, a kind of difficulty in the challenges of maternity practices and wide variation across hospitals, both in the United States and globally. Confusion about recommendations, which again, Lars talked about even with the vaccine rollout. Valuing of prevention, but also the fact that in some hospitals, lactation staff or midwives were furloughed or redeployed. And a call for a need for telehealth, but also understanding that telehealth does not replace expert technical assistance for the new breastfeeding family. So in our global meetings, we have noted that breastfeeding initiation rates have decreased around the world, that midwives have often been redeployed to care for COVID patients instead of breastfeeding and birthing parents. We have seen in hospitals globally that lactation staff have been in some hospitals either furloughed, redeployed, or deemed as non-essential personnel and not have the ability to actually see parents in person. Families have experienced separation in birth and a lack of skin-to-skin contact and direct breastfeeding, despite the World Health Organization recommendations for early exclusive breastfeeding. This has not occurred universally around the world. Early discharge, and we've also seen aggressive formula company marketing in some countries. So when you think about the toll that this has taken, okay, this from our white paper and global task force meeting, there has been tremendous pressure on healthcare systems and a prioritization of care of COVID patients. And so a deprioritization of care of childbearing families. There is fear amongst staff, amongst families, and there is confusion. In a survey that was done, market survey that Medela engaged in, they did a survey to both maternity staff and NICU staff. They found that 50% of mothers were being discharged earlier globally. There was an increase in maternal infant separation. There was an increase in the prohibition of visitors, so no visitor access, and sometimes including partner access. And this is really significant because a lactating parent shouldn't be expected to go through the breastfeeding journey by themselves, nor should they be expected to birth by themselves. There's been a decrease in technical breastfeeding assistance at the bedside and a 50% reduction in breastfeeding support. When interviewing specifically the NICU staff, again, NICUs report increased separation of mothers and infants. In my area, in the Philadelphia region, we actually had a NICU in our region who closed their NICU for over 5 months to both mother and father. So there were no parental visitation at that unit. And the only thing a parent could do was drop off milk at the bedside. 27% earlier discharge, restricted access for mothers, reduction in staff. This is something that has been a huge global problem as staff have been redeployed to care for COVID patients, as staff have been extremely stressed, okay? Staff reported increased formula use in the NICU, and staff also reported decrease in the initiation of pumping and breastfeeding. So there is a lot of stress related to COVID. All of us have been living in this COVID world for 10 months and experiencing stress. From a family perspective, the family has the stress about giving birth without the support of a partner. They have the fear of infection. They have reduced access to care. They're confused because of all the conflicting practices. We have the challenges of physical distancing and confinement measures, and we have the economic impact. When we interviewed first-time mothers early in the pandemic in the Philadelphia area, we found similar experiences. And these were all mothers who had healthy full-term infants and all who delivered at a baby-friendly hospital. Despite that, they reported similar concerns. They reported that every day they received different recommendations, whether to mask or not mask, whether or not partners were able to be present or not present, whether or not they were going to have in-person care versus telehealth care. It was very stressful because the recommendations were always changing. They had high levels of guilt, concern, stress. They were worried about leaving the house and catching the virus. They were worried about putting a burden on their healthcare providers because they didn't believe that breastfeeding was as important as those care providers providing care to COVID patients. They talked about the fact that telehealth visits may be convenient because they didn't have to leave the house. They really did not think they were effective when thinking about things like attaching a baby to the breast. And one mother talked about how she had to have her partner hold up her computer for the IBCLC to look at the latch, and she didn't even know if it made a difference. They reported grief about missing time with their families and friends. But silver linings included that they had time at home to be able to just breastfeed their baby. And that was important because in America, many women have to go back to work very quickly after birth. So in our manuscript, we really present a call to action. And that's what I'm going to focus on for the rest of this talk, because we have to acknowledge and address disparities. We have to address the critical role of human milk as a life-saving medical intervention, as Lars discussed. We have to change the current prenatal care paradigm, and we have to better engage and empower the family members so that parents can meet their personal goals. We have to have a sense of urgency about milk supply, and we need to increase access to pasteurized donor human milk, not as a replacement to mom's own milk, but as a bridge. So we know global evidence shows, whether you're in the US or any other place in the world, that the current practice paradigm really is not ensuring that all families are meeting their goals. We have low exclusivity rates globally of exclusive human milk at 6 months. And again, we've seen a decrease in breastfeeding initiation since the start of COVID. So this has a particular health disparity lens and importance because, for example, if we look at non-Hispanic, Black, and Latina populations as compared to white populations, we see significantly higher rates of otitis media. We see significantly higher rates of neck. We have significantly higher rates of gastrointestinal infection, and we have higher rates of child death for both Latina and Black infants. So there's tremendous health disparities that have a long-rooted culture, in particular in the United States. We have to acknowledge these historical antecedents that have impacted breastfeeding, and we have to really understand the health equity concerns because they are real. And we heard in our global roundtable that this has occurred in the US during the pandemic in New York City, where breastfeeding rates were significantly lower in Latina families during the pandemic than women who were of Caucasian descent. We also heard in Europe the disparities in healthcare for families who had resources or higher income versus those who are lower income. We know that disparities exist in initiation of breastfeeding as well as access to pasteurized donor human milk. So in the US, not only are African American women less likely to initiate, the hospitals that serve them also don't have PDHM for the vulnerable infant, okay? So we really have to address these issues of structural racism and inequality because not breastfeeding has an intergenerational impact. So we have to think about human milk and breastfeeding as being critical. When we think about human milk and breastfeeding, if I was not breastfed as a child, I am more likely to have health concerns. Diabetes, obesity, hypertension. I am more likely to have adverse birth outcomes that also may impact my ability to effectively breastfeed and establish lactation. However, human milk is so critical, in particular at this time, to really mitigate against toxic stress. We have the socioeconomic impact, the ability for parents to be able to provide milk and not have to be worried about being able to afford formula or find formula. The positive impact of skin-to-skin contact on attachment and developmental outcomes. And the components of human milk that are critical for both short-term and long-term child health and development that Lars so clearly articulated for us. We know that during this pandemic, families may not have economic resources to purchase formula. We've seen a big impact on women and women having challenging times with combining work and childcare. We know that there has been a significant loss in jobs for women disproportionately compared to men. And we also know there's been price gouging and lack of access some places for formula. So if we start with helping families make an informed decision prior to birth, we don't have to worry about formula. So all families deserve information about the science of human milk. And human milk and breastfeeding should be addressed at every point of contact. And I see this every day in my clinical practice when I meet families who come from other hospitals, they may or may not been given information about the science of human milk and why it's critical. And so we really have to question our current paradigm in how we're delivering prenatal care. We need to ensure that all families have the opportunity to make informed decisions. We know that globally, that many people don't initiate breastfeeding due to culture, a lack of family support, a lack of education, or a lack of exposure. So we want to take this opportunity to use the pandemic as a way to address the life-saving impact of human milk and breastfeeding. We know that it's going to impact the family, not only short-term, but long-term. We also need to set them up for them to be able to meet their personal goals. Families need to understand not just that breastfeeding is good, but the actual science of how the milk is protecting their child. They have to understand the physiology of lactation. They have to understand how their body works to produce milk. And we have to prepare them that breastfeeding takes time and effort and commitment. And this is so important during this time of COVID because, again, we have seen decrease in hospital support and assistance for breastfeeding. We have published about our group prenatal care. Again, the role of midwives is so critical and the centering model. And at Children's Hospital of Philadelphia, we use a science-based approach, teaching about the science of human milk tailored specifically for their child, as well as the physiology of lactation. And this is done with the entire family, not just the mother or the lactating parent. And you can see our outcomes show that there's 100% initiation of human milk or breastfeeding. And this is not just short term. This is throughout the entire hospital stay. And all of these children are children who had complex anomalies that could preclude breastfeeding. We're actually getting ready to submit a paper now where we've looked at the long-term impact post-discharge of families who've had prenatal intervention. And we are seeing significantly higher rates of breastfeeding at 6 months, at 1 year, and beyond. Now, we also need to identify risk. And this is something we talked about quite a bit yesterday at our roundtable, because we do have families that come with risk factors that could delay the development of a complete milk supply or could delay them effectively coming to volume. So we do have some parents who may not be able to make a complete milk supply. And we should be providing them with appropriate anticipatory guidance. So for example, if there's alteration of maternal anatomy, augmentation, reduction, breast cancer, chemotherapy, radiation, all of these things may negatively impact the ability to actually have a complete milk supply. So in this case, our conversation prior to birth needs to be, how do we help you maximize your personal milk making capacity? Because every drop of milk does matter. And for parents who have insufficient glandular tissue or glandular hypoplasia, this needs to be identified during the antenatal period, because we know these parents are not going to provide 100% of milk to their child. So we don't want to set them up to think they can, because then what we see is parents experience post-traumatic stress from those experiences. So parents who may not be able to have a complete volume of milk need choices, and they should be presented prior to birth. Whether they're going to access informally shared milk, which is controversial in some countries, the FDA does not recommend it. Are they going to use formula, or are they going to attempt to access pasteurized donor human milk? We need to engage and empower the family. And this is so critical, again, in this time of COVID. We can't just be relying on one person to have the knowledge about breastfeeding and the establishment of lactation. We need to engage the other family members. So what is the ability to quarantine family members together prior to birth? What is the ability to set up a breastfeeding support network prior to birth? And even if we are using physical distancing, we could still set up networks for grocery delivery, meal delivery, laundry pickup, laundry drop-off. There are ways in which we can support that family, even if the family can't be together. And we want to have the family set up a contingency plan. And this is something we talked about quite a bit yesterday, because we would hope that breastfeeding would be smooth and effective at the start. But we know that is not always the case. And so we might need to have contingency plans, because we have to have this sense of urgency about milk supply. We have increasing evidence from work that I've done at Children's Hospital of Philadelphia, by Leslie Parker's work at the University of Florida, by Paula Mayer's work at Rush, and Rebecca Hoban's work. We know that there is a critical opportunity to engage the lactation process to establish a complete milk supply. So, ideally, the prioritization needs to be on early initiation of breastfeeding and skin-to-skin contact. But as we know from the Global Roundtable, this has not happened every place in the world. We furthermore need to address that for any of the following, if there's parent-infant separation, the infant is not feeding well, or there are lactation risk factors, we have to prioritize the protection of milk supply. So we may need to do very early initiation of pumping or milk expression. So that means the bedside nurse in particular, because that's the person who's with the family 24 hours a day, 7 days a week, needs to understand risk factors that both the mother and infant can have. We should be addressing them ahead of time whenever possible. And the whole healthcare team, and we talked quite a bit about this yesterday, it has to be the OBGYN or the midwife. It has to be the pediatrician. It has to be the nurse. It has to be the lactation provider. Everyone needs to employ a proactive management style to ensure that we come to full volume. Lastly, I just want to address the access to pasteurized donor human milk. So we know that there is not universal access for PDHM around the world. We also know we don't want to use PDHM as a replacement to mom's own milk, but it is an important bridge. And at my institution, we include parental preference as a reason for using PDHM. The Human Milk Banking Association of North America has not experienced any shortage in donors or in donor milk all through the pandemic. And so, in fact, the supply of donor milk has exceeded the need for it. So we have to think about this as a potential bridge and increase access globally, but not ever as a replacement to mother's own milk. Thank you very much. And we have about 10 minutes for questions.
Thank you, Diane and Lars, for that great information. It was so eye-opening and so informative. A lot of information given in that 50 minutes. Thank you again. Just a couple quick things before I hand it over to Nania to go through the questions that have come in. I have had some questions about handouts. We'll get those to everyone that's on the call after the webinar ends later today. And we'll also provide a link to the article that Lars spoke about in the beginning of the webinar. For the U.S. attendees, certificates will be available by logging into your account on Monday. And Nania, if you're ready to start the Q&A, go right ahead.
Thank you very much, Kim. And again, thank you, Lars, and thank you, Diane, for that excellent presentation. I think your presentation really underlines that urgent need that there is to provide clear and especially evidence-based guidelines so that healthcare professionals can be empowered to develop the right protocols to protect and promote breastfeeding and lactation. So let me look at the questions here. Bear with me a bit. I'm having trouble opening this. Okay. We have one question here. If you don't heat up pumped milk and it got transmitted while handling it, will the virus be eliminated just as it would if pasteurized?
Yeah, I'll take that question. So if I understand that correctly, if you don't pasteurize or heat up milk and it does get contaminated through pumping handling, there is virus in the milk, there is a chance of contamination or infection, but it all depends on the load of the virus, right? If you get just a few virus particles into milk, that doesn't necessarily mean that your infant gets infected. So we don't really have any information, but if virus is in human milk, that virus can potentially be infected.
Thank you, Lars. Here we have another amazing publication and great sharing. Thank you to Professor Bode and Professor Spatz. And the question is, what are the research topics we can focus on at a country level to improve clinical practice and health economic evidence so that we can better engage local policymakers to provide resources to support breastfeeding and human milk practices?
I can start with that one. I think that there are several things we have to consider. We already have the evidence that human milk and breastfeeding makes a long-term effect on both the mother and child. I think what we need to really help government officials and policy officials understand is the investment that we need to make early and often with the breastfeeding family. Even prior to COVID, we would see that breastfeeding rates often drop off quite quickly after the birth of the child. And so this idea of changing that way in which we provide antenatal care, I think, is critical. And then the care that occurs during that first 7 days for milk supply. Because if we don't have milk supply short term, we're not going to have milk supply long term. And if you think about childbirth and childbirth preparation, all of this time is spent focusing on the birth of the child. But the birth of the child is 24 hours or 48 hours if it's a really long labor and delivery. But the lactation part of it should go for a year or more. And we're not investing what we need to be able to help a parent be effective in establishing supply. So I think that's how we have to reframe it for our policy makers.
Thank you, Diane. We have another question somebody was missing the information about COVID immunity passed through breast milk.
Yeah, I'll take that one. I think there's two aspects to that. So one is mom gets infected with the virus, and the other is mom received the vaccine. And in both cases, the idea is that mom, either infected or receiving the vaccine, developing antibodies against the virus, and then passing on those antibodies through human milk and to the breastfed infant. And I showed the data from Rebecca Powell that there is great evidence that those antibodies are actually present in human milk. And we're currently studying whether antibodies are in human milk when mom gets vaccinated. So that's really what we mean by passing on immunity to the breastfed infant.
Thank you, Lars. Have you noticed any decrease in donor milk to milk banks during the last 6 months? Noticing a local concern, or maybe have been more public service announcements or anything of the sort?
I can take that. We, Himbana, and the executive director of the Human Milk Banking Association of North America, is someone who I'm very close with. They have had no shortages in finding donors. And in fact, the supply has always, surpassed the demand. In our global task force, we did not hear any shortages reported in Europe through the European Milk Banking Association either, in terms of being able to have enough donors to meet the demand.
Thanks. We also have a question about if there is a statement or a recommendation from WHO or the CDC for the COVID-19 and breastfeeding, because for the vaccine, because apparently in Canada it's still contraindicated.
Sorry, I was having a hard time unmuting. There's a statement from the CDC, the Academy of Breastfeeding Medicine, American College of OBGYN. So there are actually several position statements that support and endorse the vaccine for breastfeeding families.
Thanks. And there's also a question if there is any evidence to support the fact that mothers are thinking, some mothers, after they receive the vaccine, they have a newborn and are giving the siblings breast milk, hoping to pass along the antibodies, and if there's any evidence to that.
Yeah, why not? Would be my answer to this one. If you pass it on to the sibling that is supposed to get the breast milk in the first place, because it's the last born, why not pass it on to others? In fact, we've heard this multiple times that even the parents, the father and the grandparents, get a sip of the milk as well, in the hopes that there is some antibodies passed on. There's even entire efforts behind that, just like you look at plasma from recovered patients to see if those antibodies might potentially be helpful, that you do that with human milk as well. Of course, the milk should always be reserved for the breastfed infant first. And then if you have access and there is valuable antibodies in there, you can potentially give that to family members or donate that, always with a caveat that milk sharing, of course, comes with its own issues.
And that's clear for when the mother has had COVID-19, but in the case a mother is only, in inverted commas, only vaccinated, do you think there would still be that?
Yeah, I think it's exactly the same story. The whole idea is that vaccination is mimicking parts of a real infection, and the response should be the same in the sense that you build antibodies against that pathogen, in this case coronavirus, and then be protected if the virus hits you in the real world. So the idea is that you make some antibodies. It will not be exactly the same antibodies. It will be very specific to the epitope that the vaccine brings in. But the idea is that you build antibodies, and those antibodies will be handed over through human milk.
Thank you very much. We're nearly on top of the hour, so Kim, if you want to wrap up.
Sure. Thanks again, everyone, for joining us today for the webinar. Diane and Lars, your information you delivered was excellent and very timely. Just a couple more quick things. Certificates for U.S. attendees will be available Monday by logging into your account. We'll send out the handouts and a link to the article that was spoken about at the beginning of the webinar later on today. And you can visit medilaeducation.com to find out more information and to register for our February 17th and our March 17th webinars. Thank you again, everyone, and enjoy your day.
Thank you very much. Bye.
Thank you.